Okay, so we left off in the middle of the oral hypoglycemics, which remember will be the content of our quiz next class. I'm here, but I can't hear anything. Okay, well, at least we know you're here. Okay. All right, so Piaglitazone is another medication that's often added with others. It also decreases insulin resistance at the tissues, at the cellular level, like metformin, although metformin has several other actions as well. This is taken every day with or without food, which is different than the other medications we've taken. There were other medicines in this class which were much more commonly prescribed. However, some of them were taken off the market because of fluid retention. So for some people, medication causes fluid retention, which can exacerbate heart failure and has led to some cardiac events. We can see here heart failure and then coronary artery disease. So you have to be very careful with people with heart disease. So I think that's sometimes why this medication isn't prescribed as much. Other things that are also bad, this is a real problem for any medication that's supposed to treat diabetes because it increases cholesterol and triglycerides. So it's already high risk. Someone with diabetes is already at very high risk to have a heart attack or some kind of cardiac event. And they're already probably going to be on medications to lower cholesterol, and then this medication increases cholesterol. So that is not another reason why it's not prescribed as much. It can injure the liver, which we talked about in the morning, the symptoms of hepatotoxicity. It can increase fracture risk in women, increase risk of infertility, and increase risk of bladder cancer. So having a history of bladder cancer is another reason that people aren't prescribed this. So it has a lot of extra things with it, so you won't see it as much. This next medication is an alpha glycosidase inhibitor. So alpha glycosidase is an enzyme that's in your intestine. So when you eat carbohydrates, this enzyme will help break down carbohydrates into a way that's easier for the body to absorb in the intestines. So if you block this enzyme, which Archibos does, then you won't absorb as much carbohydrates. So your blood sugar will go down and you may even lose weight. So this medication is taken with the first bite of a meal. If you don't eat, you don't take it, because then you would have a problem. Side effects are nausea and diarrhea, adverse effects, liver dysfunction, which we've already talked about, iron deficiency anemia, which is different from the other anemia. We talked about metformin causing a B vitamin anemia. So the person had weakness, fatigue, pallor, feeling cold, and then they have that cherry tongue, where in iron deficiency anemia you wouldn't have that. And then another special thing which is important to remember for the exam is that if the person develops hypoglycemia, which is a risk for all these medications, you can't take orange juice or crackers or something that will increase blood sugar in that way, because you're blocking the breakdown of carbohydrates in the intestine. So we can't give anything that'll help. We have to instead give glucose tabs because that does not require alpha glycosidase in order to absorb. So that's very important because that's a difference in instructions for hypoglycemia for these patients. And then the last oral hypoglycemic is in the family of gliptins called Cytoglyptin. And this works slightly differently. It does increase the release of insulin, just like, so that means it's stimulating the pancreas, just like glipizide and rapiglinide do. And it decreases available glucagon, which means we will not release some of our storage glucose. And it does this by increasing a different hormone called incretin. So this is taken daily with or without food. Most common side effect especially is headache and nasal congestion. Adverse effects include pancreatitis and Stevens-Johnson syndrome. So that's what the quiz will cover next class. We're going to talk about injectables. So there are several options for injectables, including some other ones for type 2, but insulin is, of course, the main one that we're going to talk about, and that's the mainstay treatment for diabetes type 1, although it can be used for type 2. So you cannot give insulin orally because it doesn't absorb, so it's always given as a subcutaneous injection. Only regular insulin can be given through an intravenous line. All the other insulins must be given subcutaneously. The main side effects of insulin are, of course, hypoglycemia, like we've been saying, that all of these medications can cause. Lipohypertrophy is a fancy way of saying fatty nodules or bumps on the skin, and that's more common if you give the insulin when it's too cold or if you don't rotate sites appropriately. And then the other issue is hypokalemia. When insulin is released in the body, it has a tendency to push potassium into cells. So when you give somebody insulin, you can decrease their potassium. So this has always been a question on exam. What are the three main, it's a very nice select all question. What are the three main side effects of insulin therapy? And that's them. We've talked about these issues when we talked about the cardiovascular medications. The thiazide and loop diuretics cause hyperglycemia, besides causing hyponatremia, hypokalemia, and hyperuricemia. And beta blockers can lead to hypoglycemia, especially when taken with medications that decrease glucose. So we have to remember how to store insulin. Usually it's refrigerated until you need to use it. So once you start using a vial or a syringe, because sometimes they come in those dial-up syringes, you may keep it out of the refrigerator, but not more than 30 days. And you should never give it cold. You should warm it in your hands. So here we go. Look at that. Capitalized letters with memorize. So obviously this is important. Regular insulin and NPH insulin, or longer acting insulin. Their onset of action, meaning when you can expect that there's some degree of extra insulin in the person's bloodstream. Peak, when they'll feel the maximum effect, and duration, which is in the case of regular insulin, 5 hours. So you give this 30 minutes prior to a meal, whereas NPH, the onset, peak, and duration are different. They last longer. This NPH is also given 30 minutes before a meal, and these can be given, oh good, I'm glad. These can be given together, and they often are. You can mix them in the same syringe. So when you're drawing them up, you always draw up regular first and then NPH, because you want to be an RN. But if you, like you may have learned in skills, is that you have to obviously inject air into a vial, otherwise you won't be able to pull the medication out. So you inject air into the NPH and then the regular, and then you draw up the regular and then the NPH. The other type of insulin regimen is glargine, which is Lantus insulin that lasts the whole day, and Humalog, which is very, very short-acting insulin that you just give to manage a meal. So these are the two types of regimens that people can be on to manage their blood sugar. The Lantus Lispro, or glargine Humalog, is supposed to mimic the body's way more so than regular and NPH. So the body will normally release, kind of a pulse, kind of a low level of insulin throughout the day, and then it'll shoot out a bolus of insulin when the blood sugar goes up with meals. And this is how this is supposed to be. It's supposed to mimic what the body would do. The nice thing about it is It's going to cover your meals. You don't have to have like a set schedule every day. Maybe one day you only eat 2 meals. Maybe one day you eat more than that. Whatever times you want to eat, because maybe your schedule is different. So that's the nice thing about that type of insulin. Previously, it had been kind of expensive, and so for some people it would have been cost prohibitive. You wouldn't be able to do it. And regular NPH was really very, very affordable. However, drug companies have changed the prices, whereas regular insulin is much more expensive than it used to be. The man that created regular and NPH insulin in the 70s didn't even take a patent out on it because he wanted people with diabetic to get it at low cost. But things are a little bit different now in terms of who owns medications and how they want to price them. They have a lot more freedom to change prices at will, which is another conversation entirely. So if you're going to use regular and NPH, you have less injections. So that's the other nice thing about it. So we can talk about this a little bit and how you would instruct people and when they have to worry about having a low blood sugar. So this is my day, and I eat my breakfast at 8. Maybe I eat my lunch around 11 or 12, and then hopefully eat dinner around like 5 p.m. I kind of have to keep this sort of regimen if I'm going to use regular and NPH. So I would give my regular insulin here at 7:30 prior to eating my breakfast at 8, because the onset should occur at 8 o'clock then when I'm starting to eat. The peak will be 7:30, 8:30, 9:30 is when this medication will peak, which is when I should have absorbed most of my sugar. And then it lasts about 4 hours. So by the time I get to, 7:30, 8:30, 9:30, 10:30, 11:30, around 11:30, I'm actually coming down. So for lunch, I'm not really covered for lunch necessarily. So I could give another dose of regular insulin at lunchtime. Alternatively, I could, instead of just giving regular here, I could give regular and NPH at this time. Because if we look at this slide, NPH peaks at 4 hours and lasts 18 hours. So by the time I get to lunch is when I'll be peaking, and it'll be coming down throughout the day. So that means if I take these two together, I've covered 2 meals. The regular covers breakfast, and then I just had a panic that, I am recording. I just panicked that I wasn't recording. The regular covers breakfast, and the NPH covers lunch. So if I'm taking care of this person, I have to be sure they eat lunch, or they're at high risk of hypoglycemia at that time. So they have to stay at this schedule. And then, because the NPH is going to be tapering off towards the end of the day, I could either give regular insulin here at, right 30 minutes before I'm going to eat my lunch to cover that. Or if I know the patient usually eats a big supper, notoriously has a high glucose before they go to bed, I could give regular and NPH a second time. If I do that, then I have to be sure that the patient always has a snack before bed, or they could become hypoglycemic while they're eating. Because just like the NPH lasted throughout this afternoon time, the NPH is going to go on in through the night. So then I have to be sure they have a snack, or they're going to bottom out their sugar while they're sleeping potentially. So usually you give them a snack around 10 p.m. So if this is the patient's regimen, they could only have 2 injections, which is kind of nice, except that they have to have a pretty good schedule, or they're going to have issues with hypoglycemia. So that could always be a test question. What meal do I have to worry about? If I give regular insulin before supper, then I have to worry that they eat enough supper. But if I give regular and NPH at supper, then I have to be sure that not only do they eat supper, but they have to have a snack before they go to bed. because the NPH is going to peak before bed. So that could be a question. That's why it's important to memorize when the onset, peak, and duration is. So when I use this insulin regimen, I am going to need to give myself more injections, and I can never mix them. I can't mix Glargine or Lantus with any other type of insulin. So this gives me a lot more freedom. But usually people take their Lantus or Glargine before bed, and it kind of peaks and goes. It's supposed to last throughout the day, so you have this constant level of insulin. And then, depending on when I would eat, would be when I would take the other medicine. So maybe I decide to eat breakfast a little later one day. I decide to eat, I think I'm going to eat around 9. Then I would change when I gave my medicine. So Lispro, I wouldn't give it in the morning at 8 o'clock. I would give it right before I was going to eat, because it's going to take 5 to 10 minutes to start working. So then I would say, okay, I will take that around here right before I eat, so that it'll cover my meal. And then I would just do it whenever I ate again. Maybe I don't eat again until 6 p.m. Then I would just cover my meal, or maybe I eat another meal here. So I have a lot more freedom in how I'm going to give it. So if you're working in the hospital, usually there's always if you've been working in a hospital that has obviously computer records, which most do, when you scan insulin, it's going to say, are you sure the patient has their meal? And that'll be the case for every insulin, that you don't really want to give it until you know where their food is, in case there's a problem. What if there's a delay? They order their food, but it's not there, or something like that. However, you do have a little extra cushion with regular and NPH than you do with the Humalog in terms of onset of action. Anybody have any questions? Is this why they try to encourage diabetics to meet? Yes, because we want them to be on a kind of a schedule. So anyone have any questions about those types of schedules? Because there's obviously going to be questions about that on the exam, not on the quiz.
So basically you just want to make sure that they're keeping like a really good schedule so that you don't have to change too much.
Right. So it's extremely important that they keep a good schedule for regular and NPH. But they can have a little bit more leeway on the other type of schedule. If they do Lantus and Lispro, they can eat whenever they want, because they can just inject themselves 5 to 10 minutes before they actually eat their meal.
Got it. Thank you.
Okay, sure. So that's the beauty of that schedule, is it's good. Like lots of you that did that community pharmacy project were like, I did fine one day, but then the next day when my schedule was different, I totally messed it up. Well, then this would be a good regimen for you, because it can be different all the time. It just might be expense that makes you decide. So there are a couple extra injectable medications that are specifically used when the person has really high blood sugars after they eat. And that condition of having an acute rise in your blood sugar after eating is called a postprandial high. And for some people, that's a big problem. Once they eat, they're really sensitive to that, and it takes a while for their pancreas to catch up with the fact that they ate. And so if that's really the issue, you could try these other injections instead of insulin. And sometimes people even take this with insulin, but it is very complicated then, and you are giving yourself many, many injections. So the first one mimics a hormone called amylin, which is also created by the pancreas, and it's supposed to be released around the same time that insulin is. So it's supposed to delay gastric emptying, which means you hopefully will feel full faster because your stomach fills up faster, and it decreases glucagon, so you don't save the extra sugar. So if you're going to give this medication, it has to be given 30 minutes before meals, and the meal itself has to contain a lot of sugar in order for it to be effective and not just give you hypoglycemia. So the onset of action is about 20 to 30 minutes. That's why you give it and then wait a little bit, and then it peaks in 3 hours. So the issue, especially if you're taking it with insulin at all, is hypoglycemia. So this is reserved for patients that have some kind of issue with postprandial high. The other medication that was very, very popular for a while and is not as popular anymore is called Exanatide, which is Byetta. This is a GLP-1 receptor agonist, which decreases gastric emptying, increases insulin, and decreases glucagon, as well as increasing fullness. So it's supposed to make you eat less, give you more, increase the release of insulin, and decrease the release of glucagon. And the special thing about it, which was why it was very attractive, is people lost weight on it, which is also very helpful if you have type 2 diabetes. Sometimes if you lose a lot of weight, you can reverse that process. So it was very popular. However, after it had been out for a couple of months, I realized that it had an issue causing pancreatitis. So it's not used as much as it used to be. It can cause low blood sugars, and besides pancreatitis, it can also contribute to kidney disease, which diabetics are already prone to. So again, it's not as popular as it used to be. So if somebody has taken a medication that causes their kidneys not to function, what kind of symptoms will they have? Right, so they're not going to be filtering as much fluid. So they're going to retain the fluid, exactly. So they'll have edema. So in case people don't know, GFR is glomerular filtration rate, which is much more sensitive than the blood tests that we usually check, although GFR will be on the same panel, which is what's the blood test normally? BUN and creatinine, exactly. So BUN creatinine will let us know what the kidney function is. If there's less filtration of fluid, the person will have edema. The most sensitive indicator of fluid is what assessment data lets us know the fluid status the most sensitively. Wait, yes, thank you, that's great. So then I might start to worry about kidney function. If somebody has pancreatitis, what blood tests might be changed? Only if the pancreatitis is really severe, Scott, in which it's actually affecting the liver too, which can happen when it's really bad. But there's another blood test that's a little more specific to the pancreas itself. And it's the enzymes that the pancreas creates. So if there's an increase in amylase and lipase in the bloodstream, then we know the pancreas is getting inflamed or breaking down a little bit. And pancreatitis is extremely painful. So your pancreas lives right behind your stomach, very near the first part of the small intestine. So if that's inflamed, the person will have severe pain in the epigastric area radiating to their mid-back, because that's where the pancreas is. It is very, very painful to have pancreatitis. And you don't want, pancreatitis can be deadly. This has a high mortality, and sometimes people with severe pancreatitis can end up in the hospital for a really long time. So it's definitely something that you don't want the patient to have. I work in surgery, and the rule is you're not even supposed to look at the pancreas. Do not bother it. Do not touch it. It's very sensitive. Okay, so that's the diabetes medication. So we're going to take some time to do oops, where's my, I wonder if I put it in the wrong spot. I have a little case study to do, and I wonder if I put it in the wrong spot, so hold on. Oh, that was neuro. No, that's, oh, I know why. I'm in the wrong section. Sorry, guys. Just tooling around here in my computer. Okay. All right, so there's a sheet here that I want you to take a look at and try to fill in, and then after you fill it in, put it in this drop box. This sheet is looking at insulin teaching, just to be sure you're understanding that, because that's for sure going to be on the exam, about when you would give them, when will they peak, and so when will you worry about hypoglycemia. So it shouldn't take too long to do that and upload it and then kind of take a little break. So we'll return to class at 1:50. Then finish out the hormones. So I will see you then.